My name is Michelle Masucci, and I'm a healthcare partner at Nixon Peabody. I'm a transactional healthcare lawyer representing healthcare providers, private equity firms, and their portfolio companies. I work regularly with Valerie Montague and Sarah Swank, two of our panelists and telemedicine experts. And I'm so excited that Kate Woods, Chief Compliance Officer of Schweiger Dermatology Group, has agreed to participate in our panel discussion to talk about her experiences in the trenches over the past 3 months. So as the country shut down in early March, I think it's fair to say that the speed at which the healthcare providers rolled out telemedicine solutions in their businesses to assure continuity of care was simply amazing. Equally amazing was how the regulators dropped the barriers to the use of telemedicine. I think the pandemic has made believers in the value of telemedicine among even the most hardened skeptics, me included. As a client told me yesterday, the quick adoption of telemedicine came of necessity to ensure continuity of care. The tools were available, and frankly, there was no choice for many of them. The practice of telemedicine since March has proven its value under many circumstances, but has also raised some very important questions. What works? What doesn't work? What is needed to sustain the appropriate use of telemedicine, and what needs to change? We have a panel of telemedicine experts today. Each of Kate, Valerie, and Sarah have been dealing with the operational and legal challenges each day. Our goal is to lead you some of these legal and regulatory issues and to discuss some ongoing opportunities and challenges. We hope you enjoy the presentation. I'm going to start off the program with Valerie. And Valerie, could you give us a few words about yourself, and then I'll ask you the first question.
Absolutely. Thank you, Michelle. So I'm a healthcare partner in our Chicago office, and I focus my practice on both transactional and regulatory compliance. My main focus areas are both digital health and health information, privacy, and security. So I work with healthcare providers as well as vendors in structuring their compliance programs, analyzing their data arrangements, and helping them with everything from new emerging technologies to data breaches.
So Valerie, there have been some historical obstacles to the adoption of telemedicine. Can you talk about those historical obstacles?
Absolutely. So before the COVID-19 pandemic, obviously the telemedicine technology was available, it was being used, but it wasn't being utilized to the extent that we're seeing it today. And that had to do with a number of factors. So, from a CMS perspective, there were some reimbursement issues. So Medicare coverage was limited to qualifying rural areas. It was limited to certain types of originating sites, certain types of distant site providers. You were required to use real-time audio and video communication, so the modality was limited, and it was limited to designated services, so it wasn't available for every CPC code. It was very a limited range. It was also, for smaller providers or, rural hospitals, organizations that are on a tighter budget, limited staff. It was a challenge both to implement the platform and to have the personnel available to roll out that type of telemedicine program. And Michelle, as you indicated, there were hesitations by both the providers and the patients to actually take advantage of the technology, whether there would be a demand for it, whether it would meet the patient's needs for the types of services that were necessary.
So when I hear you talk, what I've seen from my providers is they were not getting paid. Many of them were not getting paid to do these telemedicine services. They didn't have the technology solutions that were necessary. And they didn't feel like they had a real close patient-physician relationship. They were afraid that that was going to be disrupted. So thanks for telling us the history of the regulations. And I'm going to now turn over to Kate. And Kate Woods, could you give us a few words about yourself, and then I'll ask you a question.
Sure. Thank you, Michelle. I am a healthcare attorney by background, and for the past 2 decades have helped provider practices and healthcare companies build out compliance programs. So currently I'm the Chief Compliance Officer with Schweiger Dermatology Group, which is a multi-state dermatology practice in the Northeast area. And my focus is generally on a whole compliance infrastructure, and COVID-19 and telemedicine has added a uniquely different layer to that entire arena.
So thanks, Kate. Could you tell us for pre-COVID, how much did the Schweiger Dermatology Group rely on telemedicine?
Zero. We had no telemedicine platform. We were able to build huge testament to our operational team, our COO and others. We built out a telemedicine platform within 7 days. Some of the reasons we were able to do that was very much so because of the CMS waivers and the various state executive orders relaxing regulatory requirements around it. I don't think we could, I know we could not have done that in a normal climate. And we really relied on the use of technology that pre-COVID-19 would have been prohibited. Apple phones, FaceTime direct with patients and things like that.
Thanks, Kate. So Sarah, I'm going to turn to you. Could you tell us a little bit about yourself, and then I'm going to ask you a question.
Great. Good afternoon or good morning, depending on what coast you're on. I'm Sarah Swank. I'm counsel in the Washington, D.C. office. I've been both in-house and outside counsel, and I focus a lot on care transformation and care disruptors, usually digital telehealth or care models and payment reform. And I guess we just had the biggest disruptor there ever was. So and also some of my work in the Washington, D.C. area, being in-house right after 9/11 and the anthrax scare, I had worked on what we call emergency preparedness, and I don't think any of us were quite prepared even for where we are now. So thanks everyone for having me today.
So Sarah, could you tell us about the waivers that Kate alluded to and the barriers that were basically eliminated as a consequence of the pandemic?
Great, yeah, so as somebody who is the opposite of in the way that she's probably worked on telehealth before, but I had spent time working on telehealth in the hospital setting, in academic medical setting, either in-house or supporting those programs since it started, from the onset of like having to wheel things to webcams. And so I would see these barriers that were there, and we would say, okay, we need to change them, for example, reimbursement, licensure, things like that. And then all of a sudden we got to watch in one congressional action, huge set of dollars getting infused into a program that didn't even exist yet. And then we watched CMS launch this program, and it changed everything. It changed that program, it changed Medicaid, and then the commercial payers kind of followed suit. It created flexibilities, not only around, for example, like co-payments and things like that, but it also changed the reimbursement model from honestly like zero, unless you were in a rural area and that very, very limited exception in Medicare, to when you looked across, Medicare, Medicaid, and most commercial payers, everyone, and it wasn't just COVID patient specific. It was we couldn't have patients in offices, one for the exposure rate, but also two, we didn't have the PPE we needed, and we were preparing for surges. So I think it was just this huge change. And then the fact that the patient could actually be at home. I mean, that's a huge change. Where the patient was. And that doesn't seem like, now we look back and probably, even though it's only been a few months, and say that's really strange. Like, why, of course the patient would be at home if you're doing telehealth. But that wasn't the case. I think the other thing that will be really interesting, exactly what you said, Michelle, is we just assumed a lot of physicians were interested, and there were some that were. And we just watched a bunch of doctors get graduated early from med school. We saw a bunch of doctors, come out of retirement, and a lot of people didn't necessarily. Some people wanted to go be in the fight, and some people want to be in the fight and do it in telehealth. So it'll just be interesting to see what will happen with this additional flexibility that came out of these waivers.
So Kate, Thank you, Sarah. Kate, I'm turning back to you. So you were there with your providers, and they're dermatologists who are used to seeing, touching patients all the time. How did they react to this? How did they embrace it?
That's a great question, Michelle, because prior to COVID-19, the majority of our providers were not interested in telemedicine. They didn't see, again, they're dermatologists, they did not see the value of a screen-to-screen interaction. You know, they wanted to have the patients on sites. There are reimbursement issues that were alluded to. But post-COVID-19, you know, we rolled it out because it was necessary. We had shut down our offices for the most part, except for emergency situations. We still had patients who did need care, you know, and things that would come up. And so we rolled it out. We walked our providers through it. And as they began to adopt it, many of them said, wow, this is so much easier than I thought it would be. And my patients love it. So providers that I would never have embraced it if it hadn't really been forced upon us, I think found the value in it. And our providers, you know, run the gamut of generations. The early adopters, as I say, were obviously the younger, but like I said, older, more mature providers who were mature in their practices, who had said previously, I'll never do it, became some of our best users of it because their patients were also more mature and the patients least likely to come into even one of our emergency center offices. I do think I'm a huge proponent of some, you know, of the waivers and the relaxation of certain rules in allowing that continued access to patient care. Because if it had been onerous, if the technology had been too cumbersome for our patients to use or our doctors to use, I guarantee you the adoption rate would have plummeted. And we didn't find that. Interestingly, we also found we live by NPS scores at Schweiger Dermatology. So it's, you know, it's a customer satisfaction score for those who aren't familiar with it. We saw our NPS scores, which were always in the high 80s, skyrocket when we went to telemedicine. And I do think it was because it allowed continued access for our patients and it was easy for them to use. So we will see as we kind of return to a new normal, as additional return to regulatory rules go into effect, what the, I guess, continued usage rate is on telemedicine. I would imagine we'd lose some patients. I would imagine we'll lose some doctors. It won't be as easy, perhaps.
Well, and I think so much of that is going to be dependent upon what rules still exist. The technology, and this is not a plug for Apple, the technology, by allowing the use of your regular phone instead of like you said, a cumbersome technology, made the adoption of this pretty simple. So Valerie, I want to talk to you about this because the HIPAA issues have been, as far as I know, a big obstacle to the adoption of telemedicine in a regular physician environment.
Michelle, I think you're absolutely right. You know, in pre-pandemic times, you know, a telemedicine platform would be a vendor to a healthcare provider. They would be a business associate. That organization would have to comply with the HIPAA requirements as a business associate and jump through, you know, the policies and procedures and the training and the security risk assessment hoops on its own. The entities would have to have business associate agreements in place with each other. So that's all beyond the services agreement and their contractual relationship. So, you know, in March, when OCR came out with their enforcement discretion guidance, they gave the providers the opportunity to, you know, put these programs into place immediately without having to ensure that the vendors were compliant with all the HIPAA requirements, without having to, you know, negotiate separately a business associate agreement. They allowed the use of the technologies that both the physicians and other clinicians and the patients already had on hand, you know, the FaceTime, the Skype, the Google Hangouts. You know, they really made it easy to transition to a telemedicine program very quickly and without, you know, additional burden on the patients or the providers. You know, whether that will remain in place post-pandemic, you know, is a little bit doubtful. I think that's definitely something that providers will want to keep their eye on and maybe, you know, take the time as things return somewhat to normal to determine how they're going to work with vendors, how they're going to put a permanent telemedicine program in place in compliance with, you know, what was the previous requirements for data security and privacy.
I keep thinking that I just don't know if there's going back from on the HIPAA issues. I guess we'll see. Kate, how involved were you in the technology solutions as you rolled out the telemedicine programs?
So initially, when we first contemplated rolling it out, the CMS waiver had not been forthcoming. And so we were looking at HIPAA compliant technologies. Like within days that changed, but initially I was involved working with our chief medical officer and our chief of operations on, to Valerie's point, is it a compliant technology? You know, there was a leading HIPAA compliant platform that we had engaged a BAA with. We bought a limited number of licenses and we're about to set that up when word came down that we could use non-HIPAA compliant technologies, FaceTime and whatnot. So we immediately pivoted. I have a really, I think, you know this, Michelle, a really compliance oriented operational and medical teams. So they tend to keep me involved, even just to ask questions. I'm very thankful of that on things that, you know, maybe other companies wouldn't. You know, once I said, yeah, you can use FaceTime, they'll still check in every once in a while on technologies and say, hey, as we get to the new normal, Kate, should we be looking at re-engaging a HIPAA compliant platform, kind of planning for the long term? And so we're actually starting to do that. We're using the technologies as freely as we can use them now, but we believe in the near future, you know, whatever that means, you know, within the year, we're probably going to need a HIPAA compliant platform. As much as I would love it if the government said, hey, you know what, FaceTime worked really well, continue to use that, I don't think that's going to happen. So we're starting to build an infrastructure around HIPAA compliant platforms.
Great, thanks. So Sarah, this is something that I know you worry about. You worry about malpractice. Can you talk to us about that?
One of the things to think about, and we thought about this with telehealth anyway, which was the idea of liability and the standard of care. And so if you look at the beginning of telehealth, I remember hearing a speaker say, well, I don't think there is a standard, there will not be a standard of care anymore if there's telehealth. Now, I don't know if I necessarily agree with that, because I think it's a modality to care for and a tool in the toolkit to care for patients. It's not the entirety of a, there are some business models that entirely do that. There are ones that just do primary care just on a technology platform. But ultimately, a patient needs to have a test. We're not going to be like FedExing all the supplies that we need to every patient for every kind of procedure. We are seeing some of that with monitors. But I think it's a balance. And even if you look at, you know, usually you go and look at based on the specialty, you go look at the society, because they set out the standards. And you're seeing the standards even having to be modified. What will be ultimately interesting is if you look at natural disasters and other emergencies, they're usually just a one-day event, and then there's the aftermath. And so if you look at Katrina and some other events like that, there were statutes put in place after the fact to work through those liability issues. And we know some of those are bubbling around Congress. And so it really is a balancing act, looking at your informed consent documents, things you're already doing, right? Going back and looking at those, looking at How are you documenting how you're scheduling patients, your social distancing, if they actually do have to come into the office, and balance that with, is this right for a telehealth visit? And it's complicated. I mean, people keep asking, how do you document it? And it's like, I think document it now the best you can, because it's going to be hard 6 months from now, 2 years from now, to try, if there were a case or an issue, to try to remember where we were at this moment, because even March seems years away, and it wasn't that long ago.
Thanks, Sarah. Kate, I'm going to go back to you. A lot of your practices, patients in New York, New Jersey, and Pennsylvania, they scattered. They went to different places. And one of the changes that happened very quickly was the licensure requirements were modified to allow doctors to see patients across borders. Could you talk just how that all evolved and how you were able to keep track of it, and even what your plan is for the future with respect to monitoring this?
Sure, yes. So you're right, Michelle. The majority of our practice is in New York, New York City and the boroughs. So we saw almost immediately a mass, migration, whether it was people leaving to go to different states to stay with family or renting places, or also simply people who worked in the city and would see our doctors, but maybe perhaps lived in New Jersey. And so we're now not coming into the city to see their doctor, but still wanted to have contact. So we looked at what we first did is we looked at the 3 states we were in brick and mortar: New York, New Jersey, and Pennsylvania. And I guess the silver lining of being 3 states that were hard hit by COVID-19, every single one of those states had either implemented a waiver where we did not need to obtain licensure, or a very simple process to obtain licensure to practice telemedicine across state lines. So for example, the New Jersey application you could do online. It took less than 5 minutes. It might have taken less than 2. So where we needed to, and in Pennsylvania, initial guidance was we had to notify and fill out a form. And then as we did that for a few of our providers, we received feedback from the state, you don't need to do this. And then New York as well. So what we told our providers was, in these 3 states that we are in and practicing, and because your patients may have relocated to any of the 3 or be there, complete the New Jersey waiver application and practice. And we immediately opened up everything for those 3 states. But we also found that we had patients who had, migrated to Florida, as an example, or Connecticut, were 2 big states for us. Florida had a waiver. We said, okay, you can see your patients in Florida, but I would have to monitor, and still do monitor, as different states, either their executive orders expire or they extend them. I monitor those daily. One thing we had to do, and it goes to something you said early on in the call, Michelle, there are 50 states. We have a limited resource, and we cannot spend every day ensuring that we're up to date on 50 state rules around interstate practice and telemedicine. So we limited it for our providers. But as I said, we said, you can do it in these 3 states that we practice in based on the current rules. We opened up Florida, we opened up Connecticut based on the rules as we knew them, and Virginia. We said, for other states, if you have a patient who is in that state and we don't know the rule, you will have to find it out on your own. And if you inadvertently practice in an inappropriate way, you bear that burden to some extent at your own risk. So by doing that, what we found is our providers were comfortable with the advice and guidance we were giving out, and we've kind of retained practice in a handful of states. So if we have a patient in California, for example, where we have told our providers not to engage in telemedicine, unfortunately, they will tell the patient that they can't do the telemedicine visit. I hope that answers your question.
It does very much. Valerie, do you have any sense, and I don't mean to put you on the spot, but I am, do you have any sense of how those licensing laws might stay in place, those changes might stay in place, or how they might change, or if the flexibility is going to be retracted? Is there anything that you see?
I think we'll see. Yeah, I think we'll see a little bit of both. I think the formal waivers and other guidance that's out there will likely either expire or terminate post-pandemic, or if it's time limited when that time expires. I do think that we will see continued flexibility. I think we're already seeing it. I think the governor in Idaho wants to make their flexibilities permanent. I think that people understand that patients are not confined to a particular state, that, providers based on their locations or based on their patient bases, that they cross state lines fairly frequently. So I think that, even if what's in place now disappears, I think that the processes will be more streamlined for those that have an existing license in a state already to come into a new state. I don't think it'll be nothing, but I think it'll be somewhat easier, because I think there's recognition now of the benefit to the residents in the states as to have that telemedicine to continue.
Great. Thanks, Valerie. I'm the one who worries. That's what I do. And I worry about practices like Schweiger Dermatology or my physical therapy clients or others who have gone headstrong into telemedicine. And what I worry about is, how do they stay compliant going forward as the rules change? So I think I have a two-pronged question. The first is, what do you think are the key policy changes that need to be made in the future to allow telemedicine to be sustainable? And the other things are, what are ways that companies can assure compliance going forward? So the first thing and I'm going to ask each of you to talk about the policy changes that you think are necessary. And Valerie, I'm going to start with you, because as I see your face here.
Sure. I mean, from my perspective, I think reimbursement drives so much of telemedicine. So I think from a Medicare perspective, the CMS administrator has already acknowledged that telemedicine is here to stay, which I think is promising. I think we need those expanded CPT codes to continue. I think we need the flexibility to provide covered telemedicine beyond just the rural areas. I think we need the expansion on the distant sites. We need the expansion on who can provide telemedicine. So I think that's a really important policy change, because as we all know, Medicare drives a lot of what the commercial insurers end up doing as well. So I think that's, primary from my perspective.
Sarah, what would you say? Thank you, Valerie.
Yeah, I think the two things that were always holding it back were licensure and reimbursement. But I want to dig a little on the reimbursement for a second, which is, right now, for at least for CMS and even the commercial payers, you're getting paid an in-office rate. So will that stay? And I think that will come down to efficiency. So was that visit as efficient and cost efficient, right? Not and quality care, but cost efficient. Right now, if you can't get through, whether it's broadband, which I think is a huge issue, and whether it's broadband, user error on the doctor side, user error on the patient side, you had a platform. I mean, how many of us have been on like a Zoom call where we thought everything was awesome, and then like people are ziggy zaggy and you can't talk and get kicked off? I mean, so we need the telephonic visits to count as much, because we need that backup. You can't come into an office necessarily. But what will happen in the future? I seriously doubt they'll pay an in-office rate for a telephonic visit, and that might transform care altogether, that there might even be a tiered approach to it, right? That you would actually get paid for a telephone call. It's something that we don't usually do. So I think that that's huge. But I think the licensure thing will be interesting because we've been trying to work through compacting and compacts and even just like competency for telehealth, right? Because we just put a bunch of doctors on there and said be competent for it. And it's a different way of seeing a patient. And when we go back to it's not even just liability, but just care. So we can look into the future and see we should start training our doctors differently. But we said that a long time ago when like the first iPad showed up in a residency program. So I mean, I guess I would say reimbursement, licensure, and really maybe education are things that we really need to look at from a policy perspective.
Thanks, Sarah. Kate, now that Sarah mentioned the competency issues, were there any issues that you saw at Schweiger that you had to drill down on, or?
Yeah, so some of our providers, few, I have to say, surprisingly few, were not able to adapt to the technology for the visit. We did not mandate telemedicine during this time. We built the infrastructure. We said, use this. You will be able to continue seeing your patients, and patients will continue to have access to care. But if there was a provider who, for one reason or the other, could not adapt to the technology and had the competency to have the visit, during this time, we didn't really address it at all, Rochelle. We said, okay, you don't need to engage. I think, to Sarah's point, it's probably a key piece of any sustainability around, a massive telemedicine push. I do think historically governments do think about that. So when you think about transition to EMR records, right, from paper to EMR, there were timelines. So you'll adopt this behavior. If you do it now, you won't be penalized. If you do it at this point in time, you'll be penalized. My guess is the same might happen if we do a massive push to telemedicine for the same, the same thing. I think it's about use of technology. I think young providers, you don't really need to have additional training. The younger they get, the more likely it is that they were born with a device in their hand and they know how to use it. I do think, as I speak with our providers just about the actual human-to-human interaction with the visits, there is very likely a competency around the care of assessment. Now, I'll speak specifically to the practice of dermatology, where you're clearly looking at skin and things of that nature, which can be a very different experience in person than it is on, a telemedicine visit. If I were creating policy around that, I would say there should be some standards around how you engage that visit, because you can easily, I think far more easily miss, the malignancy of something on a not great quality call than you can in person. But I think that's yet to be developed. And to an earlier point of Sarah's, I think it goes to a malpractice issue. Some doctors will be more conservative than others. I think in telemedicine, it probably behooves them to be more conservative with certain assessments than others. So you might have a telemedicine visit and then say, okay, you really need to come in. I'm going to need to do an in-person, look, I can't quite see it. So to the policy question, I think that lends itself to, we have a really robust debate internally about whether insurance companies are going to retain payment at in-office levels. And it's evenly split among our doctors and senior leadership staff. We have about 50% who think they'll continue to do so because it makes sense for plans. It's what their members want. It's easier during COVID-19 and even post-COVID-19. It keeps people out of offices where they don't need to be. And then we have a whole other segment that says, well, that might all be true, but plans don't want to continue reimbursing at these, higher rates for work that they see as, potentially less valuable. I think that will be a huge driver. I think we're all pretty clear about that. Depending on how various plans come down, will determine how we utilize telemedicine. Yes. So, and then on licensure, I would just like to say, because I feel very strongly about this, I think what COVID-19 has shown us is that states should not, from my perspective, interfere with an established patient visit on telemedicine with his or her provider. I understand that there are perhaps reasons for rules around new patients and things like that, but to me, what we saw is the relaxation of the licensure rules allowed our doctors and providers to continue seeing their established patients. And if they had to operate under pre-COVID rules and were not licensed, for example, in New Jersey, because they typically saw that doctor in New York, that would have been a huge barrier to patient care, and it would have directly interfered with the patient-doctor relationship. So I'm now being precluded from my choice of doctor based on an ability to license. So I would like to see the licensure rules relax, not entirely disappear, but make it easier to obtain some form of interstate licensure on a mass scale. So that was really a question, but that's really
helpful. Thanks, Kate. So my last question for the panelists is, in terms of compliance moving forward, do we have any practical solutions that we can talk to our attendees about how to monitor compliance or how to roll out your programs to minimize what I call footfalls in compliance? Maybe I'll start with Valerie.
Sure. I think from a compliance perspective, each provider should analyze their goal. So where they are with telemedicine, where they want to be with respect to what services are provided through telemedicine, which patients you're targeting, which states that you want to be in, and, follow the compliance that way. So I don't think, creating a 50-state survey really makes a whole lot of sense for a practice that is only targeting, a handful of states in a metropolitan area. But at the same time, you want to make sure you are tracking the laws on the federal and state level, that impact what your proposed program is. And I think one thing to keep in mind as we do move from, the blanket of the waivers under the pandemic to, the future of telemedicine is, if you are, as Kate mentioned, if you are going out and you are looking to work with a vendor to establish a platform for this, make sure you're doing your due diligence, because I do see that as a big compliance risk is, tying your telemedicine program to a company that may not be able to securely protect your patient data. So make sure that when you are putting this into place, that you are vetting your partners as you go through.
Thanks, Valerie. Sarah, any thoughts?
Yeah, I think one thing is it's not over until it's over. So, and it keeps changing. I mean, we were talking before we got on. One is that, some states are moving through phases faster and slower and doing steps within phases. And so it can get really complicated. It's like we have a patchwork, and then each patch can have patchworks. And so it can be difficult to monitor. I think the thing I'd want to leave everyone about compliance is, and you're going to tell I'm like a fraud and abuse compliance attorney in really old school, which is remember your compliance basics. I know, especially March, if you felt like it was coming fast and furious, just to let everyone know it was, and it's okay. But let's take a deep breath and go back to our documenting, auditing, and monitor. Just go back to our basics of what we know. And it doesn't mean that I don't think surges are going to happen, and it doesn't mean that I don't think there's maybe not another wave coming. But and I know people are going through it now in different parts of the country. But lawyers and compliance professionals, and those that depend on lawyers and compliance professionals, lean on them a little bit, get their structure back in place, and go back to those basics. And I do realize we just waived all the laws all at once that we all took 20 plus years to learn. But go back to those basics, because that's what's going to help us when the OIG decides to, come after us for like XYZ program, or if you've got one of the FCC program dollars and they go back to look at it, they're not going to go and say, oh, that was great, we know you were in the middle of a crisis in a surge. They're going to say, okay, show me your policy, show me your documentation, pull this out, and you're going to get audited. So I think go back to your compliance basics if you can, knowing, again, the world completely changed and all the laws changed.
Great, Sarah. Kate, you have any practical solutions?
So first of all, I'd love what Sarah just said, and it's like music to my ears as an in-house compliance officer, because that's key, and I think we should build them in. And I will say, as a practical matter, being in-house with a business, we worked really hard understanding that all of the rules had just been thrown out the window for the most part, that it still didn't make either patient sense or business sense to just operate as complete cowboys. So while we were very appreciative of the relaxed waivers and rules, we identified where we thought our greatest patient need was, and we limited the scope of our telemedicine practice to those areas. As I said, the 3 states we're in and a few others, and that allowed us to control the compliance and the quality of the interaction. Because we know our compliance resources, we know our staffing resources, in order to ensure that we could in any way keep a pulse on, are we doing the right thing? Have the rules changed again in those states? We had to make a decision, a business decision, frankly, of, okay, it sounds great to go in and do this in 10 or 20 states, but the best thing for our practice is to kind of hit that 80-20 rule. And I think we'll continue to do that, because otherwise, I honestly don't know how we would manage, for example, a national telemedicine program. I would need a staff of 20, or have, a significant outside counsel ongoing monitoring. And that would be, frankly, not business savvy. You would completely lose the return on investment. So we looked at it from that as well. Like, how do we remain relatively, compliant in an unknown world while still getting the return that the open telemedicine kind of borders allowed us, right? We thought there was a balance, and we think moving forward, there will continue to be a balance. I don't ever see us going, national with it.
Thank you, Kate. I think that's all we have for today. We can open it up to questions and answers. So we have one question, and this is for Kate. Kate, what did you see as the biggest challenge to the rollout?
I think the biggest challenge to the rollout was operational. We have practices in 3 states. We're a relatively large practice. We have a call center centrally located in New York City, and we needed to ensure that our call center professionals knew which providers in which states could see patients who had moved. And then for me specifically, I think the hardest part was just keeping on top of any new executive orders as they rolled out, or questions as they came in from doctors. So we never knew where a patient would be. A patient could call up one day, previously was in New York, located in New York, would say, "Hi, doctor, I'm in Texas. I moved down to be with my family during this epidemic." And I would get real-time emails or calls. Can I see this patient? Can I not see this patient? Do I need to tell them to cancel their appointment? Things like that. So I think the hardest part was the real-time nature of some of the decisions we were making, but also just the communication between, cross departments. Okay, I know that Dr. X in New York did obtain the New Jersey waiver, so she can see her New Jersey patients, but Dr. Y has not done that, so he can't see his. Kind of the management of real-time information, probably the most difficult thing.
So, Kate, I remember when in the beginning of the pandemic, I remember contacting Valerie and I said, all these clients are moving over to telemedicine and none of them are calling us. I don't understand why. Don't they need legal advice? And she said they ended all the rules that we were advising on licensure, on reimbursement. They all, as Sarah said, they got thrown out the window. And it was then that I started to really be thinking and being concerned about, now how do we scrambled the egg and it's going to start being unscrambled at some point. So it seems to me that it's so important on a go forward basis to keep our eye on all of these issues. And I don't know that there's a real streamlined way to do it aside from business point of view, narrowing your focus so that you have the handful, or that's not a handful, it's a lot of rules that you have to keep track of on a real-time basis to make sure that you're compliant going forward. So I
that's right. We agree. But I think there can be sometimes from the business perspective, like, woo, the rules are all gone, let's go do everything. But if you stop and take a deep breath, which I think my CEO is very good at doing, you say, okay, is it really we can do anything and everything? Or will that not even, like, it sounds magical, but there may not even be a business case for that. And while we're solving for today's problem, let's at least think a little bit about what this will, return to in the future. So while we really kind of scrambled real time to get something up and running, and we absolutely took advantage of the waivers and all of the relaxed rules, we did try to keep in mind, okay, let's try to build this once. Let's not build this for COVID-19 Wild West and then have to rebuild it in 21. Let's build the infrastructure and the operational procedures around, a conservative and compliance-oriented model. Now, that being said, we completely took advantage and utilized, all of our access to technology and being able to see our patients in states where we before would not have been, but we did try to build into our structures a long-term plan. Mm-hmm. I see a question from someone, Michelle, if you don't mind if I answer, someone asking how we obtained executed consent forms. So we are a fairly technology-oriented practice, and we do a lot of things through HIPAA-compliant Clara portals. So we obtain consent forms in that way. And then in some instances, Valerie can speak more to this, some of those consent forms were no longer applicable. And when they weren't, we didn't seek them. So I hope that answers Michelle Wells' question. But I do think technology is our friend in telemedicine and other things. And we, again, as Michelle knows, leverage it fairly frequently with our interaction with patients.
I see a question, and I think Sarah's probably good for this one. What's your prediction as to whether Congress will enact a law amending Section 1834M related to the permanent removal of the geographic and originating site requirements for Medicare telehealth?
Boy, if I can predict what Congress is going to do, then I should get paid lots of money. No, I'm just kidding. My prediction would be that the more pressure we get, especially from the Medicaid population, because if we look at we already knew this, right? Where the Medicaid population was going to be a bigger percentage of the population. We knew that 10 years ago when the Affordable Care Act passed. And now we're 10 years later, and now we're in a pandemic where we look at the age group that varies. It's 65 to 100 and something. And we say to them, oh, that population doesn't really want telehealth. Well, everyone just used telehealth. And so we're going to have this real data. And so that's a real voting block right there. If that goes well, I also think the pandemic's not over. And pandemic is one definition. That's a World Health Organization definition, which we may or may not be leaving the World Health Organization. We also have a definition for a national emergency, and we have definitions of like state emergencies. Those are triggering a lot of technical legal things that obviously we felt coming at us like tsunamis one after another. But so it will be interesting. They'll have to make a decision when it's quote unquote over. And Congress can make a permanent change in the statute. We could see CMS relaxing some things and come out with regulations. But it would be great if it came from Congress. And it will be looking at, if all the healthcare providers and all the patients thought that was a good thing, it would probably be more likely to happen. When that will happen, we may be in this for a year or two, so I'm not sure. It might have momentum now. Sometimes it's like this is the chance to make the difference and the changes because we have people's attention.
Thanks, Sarah. And Kate, I don't know if you know the answer to this. Have your visits, now that you're reopening, the telehealth visits gone down? Are they maintaining stability?
Mm-hmm. So we look at our telemedicine numbers every day. They have decreased, but they have not dropped significantly. So during the 8-week period of April and May, we were a telemedicine practice. Now it still makes up a not insignificant portion of our visits, but as we're reopening, as people are comfortable coming into the offices, and as their appointments are coming up, the telemedicine visits are decreasing. We project that they'll further decrease and then maybe plateau in the mid 600s a week, somewhere like that. Right now we're in the several thousands of telemedicine visits across all practices. So I think in some ways that will be a leading indicator as well, right? Do our patients still want these visits? Do they still need these visits? And we see that it will always be part of the platform, but absent a resurgence in the fall, as they talk about, the phases of COVID-19, we assume our numbers in telemedicine will drop further still.
Is it okay, Kate, if I ask you a question? I had heard that usually you can kind of predict what your demand will be at certain times of the year or even certain parts of the month, yes, what day of the week. And I've heard since they've been telehealth visits that they don't follow, obviously don't follow that pattern, but they don't follow a pattern. Is that true? Are you experiencing that?
That's a great question. I don't know if you can see my face. That's a great question. We can predict, our busy seasons. We know what happens around holidays, a Monday versus a Friday. You can predict all of those things. With telemedicine, at least for us, we found it to be a bit more difficult because a telemedicine patient will call up same day. And some make appointments, but just as often we'll have someone say, I need a visit. I would like to just come in for a telemedicine visit. We can more easily accommodate that. So you don't per se need to give us advance notice. We can get you a telemedicine visit same day. So we don't have enough data yet to say, for example, Tuesdays are our highest volume surge of telemedicine visits, or Fridays, really no one comes to see telemedicine, because it's definitely patient driven in that regard. And it's like a drop-in. I would make it maybe analogous to an urgent care center, although I would assume urgent care centers know their busy days and their non-busy days. We have no idea yet.
Thanks, Kate.
Mm-hmm.
Well, I think we're close to the hour, and I just want to thank everybody for participating. Thank you especially, Kate, for joining us and giving us some of your very practical experience. I hope that everybody on the phone and the WebEx found this to be interesting and I hope that it answered some questions and raised some other questions. And it's something I'm sure we'll be talking about for a very long time. So thank you, and hope everybody enjoys the day. And until next time.
Thank you, Michelle. I really appreciated the panel. Was happy to join.